defibrillator, when you walk in, you're going to find the person, let's say they're pulseless. So we're going to check a pulse. Mr. Spezio, are you okay? Are you okay? I'm checking a pulse, no pulse. I'm putting on the code blue button. I'm beginning CPR, all right? So if you have people around you, go ahead and say, because you'll have several people in your group, go ahead and start CPR, okay? We want to get the crash cart here, bag valve mask. We also want to put the backboard under, okay? So now we're to the point where we're putting the defibrillator on, okay? So let's talk about the parts of the defibrillator. The green down here is pacemaking, all right? So one of them is for how much electrical impulse we're going to give, and that's called output. And then one is a pacing, like how fast do we want them. So if this person is in with a heart rate of 30, excuse me, with a heart rate of 30, we want to get them up to 60, okay? So we can use that pacer to do that. And then the output is, we want to make sure that it's actually capturing. We're giving them enough electrical impulse for it to capture and give us a rate of 60, okay? That's the green. Now, the red is for actually defibrillating, which is kind of what we were talking about in the very beginning, okay? So we've got somebody doing CPR, we put the backboard under them, and we're breathing. So now it's time to put the defibrillator on. The newer defibrillators just have the front and the back pads. So you can see, either one of these, the front and the side pads. So there's pictures here telling you where to put them. So you put one on the right side of Mr. Spezio, and then the other picture shows you to the left apex. Okay, so those are the places. There's one on the front, one on the back. This older one also requires you to put on the EKG. Okay, so this one would be, according to color, this is going to be left leg, this is going to be right arm, and this will be left arm, and I'll have patches, and you'll just stick them wherever these are not. I put these on first, okay? Once you've got those on, we're going to turn it on to the red, and then we will analyze, okay? So we want everybody to stop. We'll analyze to see what the rhythm is, if a shock is warranted, and what would a shock be warranted? What type of rhythm, do you remember?
VTAC?
Yeah, VTAC without a pulse, and VFib, both of those would be a shockable rhythm. Asystole is not a shockable rhythm. Okay, so if we've determined either one of those, then we're going to shock deliver. We might even do another one on top of that if we don't get anything back, okay? Then we're going to continue CPR. This little part over here is for monitoring. So let's say that the patient is just real labile, they're having runs of VTAC, they're doing all sorts of weird stuff. So we may send them to CAT scan with this monitor on so that we can keep track. And some of these monitors have like blood pressure cuff and other things that you can attach so that you can continue the monitoring while they're going, okay? So once these are on and we've defibrillated, let's put the situation in, how about cardioversion? We can also cardioverge. So what's the difference between defibrillation and cardioversion? Do you remember?
Cardioversion, there has to be a specific time to shock.
That's exactly right. It's somewhere in the PQRST, right? We don't want to give them a shock on the T. We want to give it at the right time, which would be right before the QRS, okay? So what you'll notice is we'll put the cardioversion on, and then you'll see a light at each time. So let's say they're in supraventricular tach and we're trying to slow them down. We want to shock them and see if we can readjust that rhythm, okay? So we're going to, we will put it in that defibrillation mode. Then when we push the charge button and the shock delivered button, it'll deliver it at the right time during the PQRST, okay? So that's the difference. Whereas, there really isn't a PQRST in VTAC or in VFib, and so we're just delivering a shock. Does that make sense? Yeah. So we would say analyze, it's upside down for me, analyze, then we're going to charge, and then we're going to shock deliver, and then this arrow is to move like let's say we wanted to do 240 joules or 300 joules, then we would move it up and down 40. Okay? And then this button would be where we're going to deliver the shock. Okay? Then once we're done, we might consider, let's say it was the full code, we might consider therapeutic hypothermia. Remember that? We're going to get a code, we're going to get an ICU bed ready. We're going to draw blood. What kind of blood would we draw?
EGs. we would draw the ABGs.
ABGs, we might get a set of electrolytes, you know, we wanna know where we are if that was part of our problem. We might get a troponin, you know, see if we had a heart attack. And then we want to, you know, look at their respiration, see if we need to intubate or do advanced airway at that time. You know, see if they've recovered at all that part, okay? If not, we would intubate and get them ready to go to the ICU. Okay, I'm trying to think of what else is on that competency. Do you have it open?
Yeah.
Yeah.
Okay, what else is on there?
I mean, pretty much then it just, you did all of it pretty much, just the assessments, like level of consciousness and breaths and
Yeah.
stuff like that.
So we're gonna do that before, and then, if you remember that ACLS video I showed you, you know, at the end, the doctor said, is she aware? And they said, you know, Mr. Smith, Mrs. Smith, are you okay? You know, so we're always wanting to go back, and then how are we breathing? So we wanna reassess, we might need to intubate, you know, if we got a good airway and we're breathing okay for them, bag valve best, there's not a rush. But we do need to do something about their airway if they're not recovering in that way. You know, if their respiratory rate's not above 12, then we might need to go ahead and consider, and many times the doctor will intubate too, just because they want them to rest for a few days if they've got a massive cardiac event. And if we're doing therapeutic hypothermia, you know, it's kind of hard to be awake during that. Most of the time people get intubated after those. Okay? So
I have a
that's-
question.
Yes, huh?
Do you want us to actually start like doing compressions, or do you want us to kind of talk it through, say, I will start doing compressions?
Yeah, and somebody stand there as if they're
and-
gonna do it, cause you know, I don't want this to distract you. I just want you to know, like, okay, so I'm gonna say, I'm the tester. So I want you to come over and start compressions, and she's gonna just stand by the bed. And I want you to come over and do breaths, and they're gonna just come stand at the head of the bed, and then you're gonna continue to talk. Cause I think if they do CPR and everything, it's gonna distract you from going forward with what you gotta do. You be the one that's responsible for the defibrillator, putting it on, and talking through what the different things are. Yeah, and then, you know, think through it, you know, I'll have given you a scenario saying this is what's wrong with the patient, and I've kind of talked through each scenario you could possibly have. And then you'll talk about which section of the defibrillator you're gonna use and what they do, and then you're gonna talk about what you would do afterwards. You know, at this point, okay, we fixed the problem, and now what do you do? So you draw labs, get an ICU bed, you know, talk about what labs you have. What else, Caleb? Do your final assessment, level of consciousness, you know, breathing, or do we need to intubate, that stuff. Okay? But, you know, I just want you to, you know, that's what would happen in the code. You know, if that was before the doctor come there, they'd say, would you mind doing this, would you mind doing that? And people start coming in, and you would take care of talking to the doctor and everything. Okay? So let's put this back here.